Liang Choo from Malaysia, Dr. Dennis Molna from Hungary, my friend Dr. Manuel Katz from Israel, Dr. Marina Orsi from Argentina, Dr. Johnny Ludwigson from Sweden, Professor Turun Tuet from Vietnam, Dr. Idoro Sagaro from Cuba, Dr. Khalid Al-Madani from Saudi Arabia, Professor Merenila Herrera from Venezuela, Dr. Jay N Shah from Nepal, Dr. Abdul Rahman Namid from Afghanistan, Dr. Kiton from Cameroon, Dr. Erkin Yakubo from Uzbekistan, Dr. Haren D. Silva from Sri Lanka, Dr. Kenneth from Uganda. My friends, it's very nice to meet all of you with a long distance scheme, and I'm very happy to join with you an international online conference of challenge in and COVID to a global perspective today, Friday on 29th of May 2020. Really, I'm grateful in spite of your so much busy schedule and of so much of problems surrounding. You have given the consent to join this meeting. So once again, I welcome to all of you and I explain my gratitude to all of you to join us. Thank you very much. Now, I will pass on final scientific program and I'll hand over to Deepak Nathia to continue this program. Our first speaker is Dr. Manuel Katz. He's from Israel. He's Director of Risk Management and Patient Safety Department of Pediatric Health Services of Israel. Dr. Manuel Katz, please.
Okay, so thank you very much. I am trying to share my slides and I hope that everything will come well. Perfect. Yes. Thank you very much. Sorry about that. I will try to manage my 10 minutes as was decided. I will try to cover mostly the issue of COVID-19 in Israel, in children, and a little bit about epidemiology in Israel now. Until today, we have almost 8,650,000 people with a population density of 400 per kilometer square, and 93% of our country is living in urban. 16,800 cases from the start of the epidemics in Israel in February 21. And today still we have 1,920 active with 2% in seriously conditioned and 281 people that they died. Today we had another 65 new cases, mainly in schools, and I will talk about a little bit about that. We had only 3,400 cases in children up to 19 years old. And in fact, very few of them were hospitalized and only 3 in intensive care. With very good progress, all the children were discharged. Only 51 for the 3,400 were hospitalized in a population children of the country of 3,146,000 children. The contagion rate in children is 1%. The admission rate in IQ in intensive care is 1 in 1 million. And the admission rate among children, infected children, is 1.5%, represent about 0.001% of the population. This is that in my country, the issue of children were very mild and still is very, very mild. If we use community screening, and in community screening, we have about 12% of children positive, and especially from age of 9 to 14. Clinical features of children, they are as in other countries, as is talking with people from different countries. But what is interesting is that asymptomatic children, we had only 15%. Most of the children positive, they were with cough, respiratory distress, and other problems. Preconditions in children that get positive to coronavirus were only 7% of respiratory asthma infections, asthma disease, and part of them with neurological diseases. Very few in cardiac diseases, prematurity, and transplant and immunodeficiency child. As another countries, religion attitudes changed a lot the epidemiology of COVID-19. Also in my country, especially in Jewish religious people, because they are in a very close population and communities with at least 9 children in at each family, and this is the most of them they were infected. Jewish non-religious in about 38% and Muslims 18%. We have those days a little bit of a new outbreak in some of the Muslims communities. When we talk about epidemiology, we see, like in other countries, 57 to 60% of children, male children, and 43% of female. But what is very interesting is the way that Israel is coping with national measures. I put in red the current situation just to have an idea, because we are about 3 months from the start of these epidemics, at least in Israel. Very early country borders closed, and still the situation is the same. We start with domestic flights. The last week, no international flights. We have very well coordinated efforts. All ministries and one voice is telling to the public. The first week, of course, twice a day, and then once a day, twice a day, once a week, and now only by news. Social distancing and lockdown today is minimal. We reopen the country in about 2 months. Schools reopened partially in May 15. The next week will be reopened for all children. Coronavirus inpatient facilities and quarantine facilities, we had a lot. We did a revolution, in fact, to facilities and community facilities. Today remain few of them. We have an aggressive identification and surveillance of contacts, especially using high-tech technology. All of us has in our smartphone app telling you if we were or not in contact with persons with positive, that gave positive to coronavirus. But we had a good test policy. Per million population is about 60,000. We are in the top 5 in all over the world. And still we have quarantine for contacts and local people and other countries incoming international flights. As I know, 2 countries started to have flights to Israel, and until today they will need 14 days of quarantines. There are some contacts with part of the countries, especially Cyprus and Greece, that probably next week will have a special bilateral agreement not to have quarantines, even people coming to their countries and people from Greece and Cyprus coming to Israel. But we had negative events like in all our other countries. We had, first of all, panic buying. People that they were afraid about to be in contact with infected people, misinformation, a lot of fake news coming from different news from different places, a lot of Twitter, a lot of Facebook, running misinformation. We have a new epidemic in Israel, like in other countries, because of the lockdown. We started to see more violence within families, and of course, a microeconomic crisis that became a very, very difficult problem. The spread of workplace closing with unemployment that rise from 3.8% one day before the epidemic starts to 24% today. And the forecast tell us that in 2021 will go to 5%. This is that 1.2 will still have unemployed. Macro and microeconomics panic. I think that we have a panic epidemic in Israel. We face some disparities across communities. Outbreak in geriatric departments at the community. This was a problem that shared with other countries, especially Spain, Italy, and others. That it was well contained now. Some barriers to care, especially in those people that they cannot contact with the doctor by Zoom or by Google or other possibilities. The people coming to the hospitals and to the community drop in about 40 to 70% in different communities. And of course, like other countries, we have green zones and red zones. Together we have only one red zone, according with the number of new contacts, the new positive people we have. Of course, measures to cope, clinical guidelines, telemedicine became the issue to share problems with patients, information to families and wellness tips in different places in the web. We have some problems talking about early childhood and children in need approaches, especially in those high-risk populations where they were at home and without the possibility to get appropriate care. Elderly people and chronic patients follow up about minus 50%, that this is a lot. And the routine children vaccinations dropped to 20% in several places. The question for us is if the reopening in the country was too early and too fast. This is a big question. We have some issues about children that school closures did not contribute to the control of the epidemic. Modeling studies of other coronavirus produces conflicting results. And recent modeling studies of COVID-19 predict that school closures alone would prevent only 2–4% of deaths, much less than other social distancing interventions. What we see, and this is very interesting to share with other countries, is that we had in these 3 months 30% less cases of pneumonia and gastroenteritis during COVID epidemics. This is because of the lockdown and because children they were at home, and this is a very interesting issue to be studied. We produced a paper about behavioral and emotional disorders in children during the epidemic, that we see more fear in children, a lot of inattention problems, irritability and other psychological conditions in children in old age, and anxiety and other emotions were heightened in children, especially in those children living in big areas. But still, and this is my last one, we have several questions. The questions about what we know about infection in children and what about post-infection findings. This is a big question for all of us. Previous diseases and risk of serious outcomes among children. The issue of Kawasaki, the true Kawasaki versus Kawasaki disease-like. Where we are regarding immunizations today. I saw Moderna vaccine is having some troubles today. To be prepared of the next winter, because we will face flu and RSV and also COVID-19 probably. What we know today on virus replication and mutation, probably we know that we have about 21 different subtypes, and probably subtypes are responsible of the Kawasaki-like disease in different countries, because this was not in the first country like China. This was developed in other countries, especially the United States and UK. Children with chronic active diseases after lockdown, guidelines has to be very clear. And what is very important is to know about serological studies, about what about them and how we can be sure about that. And PCR reliabilities, because they are countries with a very, very low sensitivity of PCR, with false positive and false negative. And there are very serious questions for all of us, all over the world, and this has to be answered. Thank you very much for the attention, and I hope to share with you all the information you need and information you say. Thank you very much.
Thank you, Manuel Katz. Thank you, Manuel Katz. Thank you very much. Now I am switching on to another speaker, and we will discuss in the last. So our important second speaker is Dr. Vana Spoulou. She's from Greece. She's Associate Professor of Pediatric Infectious Diseases at National Kapodistrian University of Athens. Dr. Vana, please.
Okay, I would like to send you my greetings from Athens, from Greece. I am an infectious disease consultant and associate professor of pediatric infectious disease at the Athens University Medical School, and doctor in Hagia Sophia Children's Hospital, which is the oldest and biggest pediatric hospital in my country. These are some nice pictures of the hospital, different places and the room. But the COVID-19 unit is in a separate building. We are a referral hospital for all COVID-19 pediatric patients in Athens. So we had to develop a separate building with a completely different entrance within the campus of the big hospital, where we have renovated it inside with 10 rooms with the system of the negative pressure, in order to admit and treat our COVID-19 patients, I'm going to share my very limited, of course, experience with these patients, because we didn't have that many in these 3 months of the epidemic in Greece. But before I'm going to present you my clinical information, I want to give you an idea of what happened in Greece with regards to COVID. So this is our country, and it took only 2.5 months for the virus to come from China to Greece. So, as you all know, the virus first hit China in December, and on the 21st of February, we had the first patient, Greek patient with COVID-19. She was a 33 years old lady who came from Milan, who was was living in Thessaloniki, who is in the northern Greece, and she had traveled to Milan and came back, bringing in her luggages also the virus. She was the first case, and 2 days later we have a cluster of 40 or 50 cases in southern Greece, in Peloponnese, who were pilgrims in Jerusalem. They came from Israel, from Jerusalem, and we had the first cases that have in the southern Greece. Actually, there was a group of 70 people, and nearly 40 of them have been infected. And from this group of patients, we had also the first death from COVID, from SARS, from the new coronavirus in Greece. And then the government in Greece, following the advice of our national experts, did restriction measures very, very quickly. So we have the first case on the 21st of February, and we have the general lockdown, including schools, 15 days later. On the 10th of March, we had lockdown restrictions in transportation, in shops and cafes and restaurants and all this. And on the 15th of March, we also had the schools that closed. And at the same time, we had a very effective and timely communication with all these spots in the TV about staying at home and be safe and taking all these measures for personal protection, which tend to be very successful, because the epidemic was put really quickly under control. We didn't have a big spread in the community. So you see here, this is March, this is April, this is May. Then the lockdown started somewhere here, and you see that we have the cluster of cases at the end of March, beginning of April, but from the middle of April till now, end of May, we see that the graph is going down, and at the moment we have about less than 200,000 confirmed cases with COVID, and 171 deaths, smaller than one. Dr. Katz said the relatively small numbers that he presented from Israel. So I think that we're more or less the same population of the two countries. So maybe we did a little bit better with regards to deaths in Greece. This is another graph showing the cases and the deaths. Again, similar, the same numbers I told you before. And there is an extensive testing in the population, with mainly with PCRs, and you see all this testing that it's negative. You see that at the end of May we have very rare positive swabs, nasopharyngeal swabs, so we feel quite safe that the virus, the possibility to meet the virus in our country is really, really low. Now I'm going to present you, as I told you, my limited experience from the patients that we have to treat in our unit. We have admitted only 7 patients, although many children that came in our outpatient department were found positive. Well, no, not many. Some children were found positive, but due to the very good general condition, they were discharged, sent home, and we kept communication by phone to see how they were going and while they was in the 14 days quarantine. We admitted these 7 patients because of the very young age. All of them were less than 3 months old, and this is a table on how these patients were presented. Actually, at the beginning of the epidemic, we were not sure if very young age could be a risk factor for severe disease, especially in very young infants that were premature or had a bronchopneumonia, pneumonic dysplasia. So we're thinking that having these conditions, this could be associated with severe disease. The children did very well, and all of them had some type of fever, not very high. Only one patient had a high fever, have some symptoms from the upper or lower respiratory tract. Some of them, 2 of them have also diarrhea, not severe findings in the chest X-ray, and also from the laboratory tests, we didn't see low leukocytes or lymphocytes, which is something that is characteristic of severe disease in the adults. Some of them has a high monocytes. No increased inflammatory inflammation, low CRP, and nothing other very abnormal with regards to their normal tests. The interesting thing is that although they did very well, they kept secreting the virus, having the virus in their pharynx for quite a long, even 35 or 45 days after admission, suggesting that this could be potentially also transmitters of the virus. And all of them have been infected by a person, either a positive relative, mother, father, or somebody who was staying in the same house. This is what I have to say. Our experience was very good with these patients. We didn't have to treat them, although we're thinking that we have to give them something like chloroquine. That was there were some discussions at the beginning of the epidemic, but we decided not to give anything to them because we saw that they did very well without any specific treatment. And actually, this is what we found, that they did very well by their own. As a conclusion, I have to say that we're quite lucky that we are pediatricians and we don't have to treat very severe cases. Of course, we don't know who could be, which child could be in danger for having severe disease. We are very interested with regards to research in my lab to see why children respond in so different way to COVID-19 compared to the elderly or patients with diabetes, and try to have some hypotheses that we were testing. And
out of time. Thank you, Dr. Vana. Thank you so much for a very elaborate presentation. Now I will invite our next doctor, Dr. Liang Choo. He's from Malaysia. He is the president of Malaysian Pediatric Association. We would like to listen from you, Professor Choo, the Malaysian experience.
Thank you very much for inviting me to share Malaysian experience on the COVID-19 pandemic in Malaysia.
Yes.
And Prof. Tomar and NIMS University.
Thank you.
I would like to share initially our experience in Malaysia.
Okay.
So it started in the first case started on January 24th, 2020, when we had a couple of Chinese citizens coming through Singapore to Malaysia. And these are the two cases. And it started our first wave, where we have 22 cases from January 24th until February 22nd, 27th. That was about a month. And we have a total of 22 cases. And then we have a quiet period. And then we started our second wave, where there was a cluster of religious group. The first group was in East Malaysia, and the second group was in the peninsula in Petaling Jaya. And that started the second wave. And we have 651 cases before the lockdown, where we call movement control order. So this movement control order was started on the 18th of March, and it lasted for 2 weeks. And it was extended because the cases were not coming down. And so far we had 4 movement control order, and now we are in a phase of movement control order, where the economic activities are now open, but the schools are still closed. All religious spaces of worship are still closed. So until yesterday, we had a total of 7,629 cases, and most of the patients are already discharged. We had a total of 115 deaths, which accounted for a total of 1.5% of all cases. So the challenges that we encounter were many, as it is a pandemic and it was not expected. So from the capacity of management, beds, until all the drugs, PPE were all inadequate initially. So from a clinical point of view, as a pediatrician, we have to actually manage the patients. I am not directly involved in the clinical management of patients, but we have to manage in the sense that we have to redeploy doctors, paramedics, and we have to plan as to how to reconfigure our hospitals and wards. So at the same time, there were clinical guidelines that were produced to help our doctors to how to manage these patients. This, as the science of COVID-19 evolved quickly, we had to upgrade our guidelines. And so far, we have had 5 versions of the guidelines. These guidelines were uploaded onto our Malaysian Pediatric Association website for our members to use. We also redeployed our doctors and paramedics, and we formed a COVID team to manage these COVID patients. These COVID patients these doctors and team were trained to how to don on and off PPE, and they were also trained about the guidelines, how to send specimen, how to take specimens and all, and how to keep themselves from infection, that they should keep clean before they go home. Of course, logistics are concerned. The first is there are beds. We have to ensure that there are adequate beds, isolation rooms, and ICU beds. We reconfigured our wards, the institutions within Hospital Kuala Lumpur. We reconfigured our ward, and we moved all patients from the main block onto other institution or blocks. And the whole main block became the COVID block, and all COVID patients were housed in the block, including pediatric patients, and our pediatric team doctors were actually moved there to see the patients. We had to also ensure that there are appropriate and adequate ventilators and consumables like ETT drugs and the PPEs. During the peak phases of COVID-19, our elective surgeries were all cancelled. As we all know, during the peak period, there were global shortage of critical laboratory and medical supplies like test kits, PPEs, ventilators, and ICU beds. But we ensure that all our frontliners who are directly involved in the clinical care of our COVID patients have proper and adequate PPEs. And this can be reflected in our very low rate of healthcare workers with COVID positive. And most of our of the 5.8% healthcare workers who are COVID positive, most of them actually contracted the illness outside work. They attended weddings and all, and they actually contracted it outside workplace rather than in the hospital. I would like to say that up to today, none of our healthcare workers who are directly involved in the care of COVID patients contracted COVID. Looking at the capacity for testing, we use RT-PCR nasopharyngeal swab to test for the virus. And during this month, we also have introduced rapid antigen test kit as well. So you can see that we have adequate beds to be used. So our capacity for bed has not been we have enough beds to be used, so we will not deprive of beds. So we don't have to send patients away to other hospitals or deprive patients and send patients home. In Malaysia, all our patients who are COVID positive and all persons under investigations are actually admitted to the hospitals. They are quarantined there for 14 days. And initially, after two swabs were negative at day 13 and day 14, they were discharged. But as from last week onwards, we have changed our policy. Now, even if they are swabbed at day 13 or 14 were positive, we believe that WHO has said that it is not infectious and we actually can discharge the patients. Due to the shortage of PPE, especially N95 mask, our Malaysian Pediatric Association actually bought some N95 masks and distributed to most of the pediatric department in the hospitals to supplement those masks for our frontliners. As there were a lot of shortages during the peak period as the pandemic was not expected, and the world were rushing to get all these PPEs, many NGOs volunteered to join and help to either make our PPEs or bought PPEs and donate. And I would say that this actually made the face shield for many of the hospitals in the country. And this was one of the donations from them to our hospital. And there were many boxes here as well. And for the gown, we were also short of gowns as well. And we have Malaysian designers fundraising, and they actually stitched and sew gowns for hospital to use. And there were many other NGOs who were involved in the donation of PPEs as well. And we also have a huge load of donation from China. So this shows the capacity of RT-PCR tests for Malaysia for COVID-2 virus. And initially, when we first started in February or March, we could only do about 7,000 to 8,000 tests. Slowly, we increased our capacity for testing, and we have a maximum capacity for over 30,000. And so far, we have not over capacity. We have not exceeded our capacity to test. So the number of tests has actually dropped slowly. So what are the other infection prevention and control measures to actually stop this transmission of COVID-19? At the individual levels, we were all encouraged to do physical and social distancing. We have these 3 C's where all public and all individuals are advised to avoid crowded area, confined space, and close conversation. We have enforcement of places of worship that should be closed. There should be no gathering, no weddings, no celebrations, and also for funerals, there should be limited number of people as well. During the first movement control order, we were only allowed to travel for less than 10 kilometers to buy our groceries. Slowly, the movement control order has now been improved, and now only interstate travel is not allowed. But for special cases, let's say patients coming from other states for medical care, they should get permission and they are allowed to travel interstates. Individuals are also advised to practice 3 W's, that is frequent hand washing with soap and water, or if they cannot wash with soap and water, to use hand sanitizer, wear face masks, and warnings such as no handshake, keep distance, and practice good cough etiquette. There was interministerial collaboration in the fight against COVID-19, and the Ministry of Finance were also involved in this lockdown. We are now into conditional MCO, and we also have another type of MCO called extended MCO, for which I will explain afterwards. During MCO, only the essential services were allowed to move on, and all other services were actually stopped. Airports were closed, and ports were also closed for travelers. Interstate, as I mentioned, were not allowed, and those returning from overseas were quarantined for 14 days. So we can see that for the number of cases since after 3rd MCO and 4th MCO, the number of cases had actually stay about the same. But after the conditional MCO over the last few days, we can see that the trend has been coming down, and we are now down to the low 2 digits. This spike here is due to increase in the number of foreign workers who had COVID-19. So how do we also reach to the public? Our Director General of Health actually holds a daily press conference through social media and the television to share daily figures as to number of new cases, discharge, deaths, and number of new clusters that come out. We also share on new information, policies, new SOPs, and the laws. So we can see that since for MCO to conditional MCO, for the past 24 to 25 days, from May, we have been doing very well, and our numbers has dropped to low double digits. Through the social media, we are also trying to communicate and engage with the public. So these are all the infographics that were produced by the Ministry of Health for public to access, so that they can gain information and practice what is advised to them to protect themselves and to protect others, and also to improve their knowledge on what is COVID-19 and when do they come forward for testing, how to protect the young, the old, and the immunocompromised people at large. So this is one of the example of sharing of information through our website. The approach that Malaysia used is targeted approach, where we detect acute cases. So when there's acute cases, initially it started with some church group and tabligh group and religious schools, and all these people were all screened and were quarantined. Then there were some travelers returning from Italy, and then this caused quite a few infection in their households and close friends, and wedding groups as well, religious flags, markets, and over the last 2 weeks, immigration detention centers and construction sites. And in the website and during our daily press conference by our Director General of Health, she was share the actual numbers and how actions have been taken to actually break the transmission of COVID-19. So we can see from modeling and projections and the actual numbers that we are in Malaysia, the numbers of COVID-19 are actually decreasing, and it was shared by our DG that if you follow the SOP that is provided by the Ministry of Health and the Ministry of Finance, then we should have less cases and into the single digit by the middle of the end of June. However, if you don't follow SOPs, then the number may increase. So we can see that our R0 has decreased from 3.9 at the beginning of COVID-19 to now about 0.3. So again, this is a different projection. This is the newest projection until 9th June. So we should see improving numbers in our country. So now we also talk about exit strategies from MCOs and transitioning to a new normal and how the country should recover from this pandemic. That's all I need to share. Thank you very much for your attention.
Thank you very much, Dr. Hung. Thank you very much for sharing us the Malaysian experience. Thank you so much.
Thank you.
Now, bye. Next speaker, Mr. Rohit Kumar Singh. He's our additional Chief Secretary of Government of Rajasthan, India. Will not joining now. He has been called by the minister. So whenever he will come back, we'll give him a switch now. Another speaker, Dr. Denis Morna from Hungary, has not yet joined. So now I'm switching on to another speaker, Professor Ron Shapiro from USA. He's a director of Mount Sinai Hospital, Kenneth Miller Transplantation Institute, New York, USA. His experience, Dr. Ron Shapiro, please. Dr. Ron Shapiro. Dr. Ron Shapiro, please.
Can you hear me now?
Yes,
Yes,
please.
perfectly.
Yes.
Okay.
Perfectly fine.
Good.
Perfectly
Sorry,
fine.
I took myself off mute.
Well done, Dr. Ron Shapiro.
Hi. So I apologize that I'll be giving this talk without slides, but I'm going to try to give you a sense of what's been going on at Mount Sinai in New York since this pandemic began. We usually do a couple of hundred kidney transplants annually and about 130 or so livers annually. And in New York City, as you know, it's sort of been an epicenter, and Sinai was sort of the center of the epicenter. So at the peak at the system, which involves Mount Sinai Hospital and also two other hospitals on the west side of Manhattan, one lower in Manhattan, Mount Sinai Brooklyn, Mount Sinai Queens, and Mount Sinai Long Island. The entire Sinai system ultimately peaked at 2,200 cases of COVID throughout the system. There were over 30 COVID units within Mount Sinai Hospital itself. There was a tent hospital across the street in Central Park, across Fifth Avenue. The public spaces were given over to triage units within the lobby of the hospital. The kidney and liver program actually were quite busy in March with, I think, 23 liver transplants and 20 kidney transplants, but we shut down the living donor kidney program sort of in the middle of March. until the dust settled, mainly for concern for the living donors. And we lost our transplant floor and we lost our transplant ICU. We were given smaller units, and we were all redeployed to help work in the virtual transplant ICU. Some of us were deployed to work in other hospitals or in COVID units. So it was interesting times, and of course everything in New York is shut down completely. From the peak of 2,200, the number of cases has reduced to now less than 300. We got our ICU back, which means we got our ICU attendings back, and we got our floor back, and we resumed donor kidney transplantation about 2.5 weeks ago. We'll be resuming living donor liver transplantation next month. Deceased donors suddenly started getting busy again, kind of around a third of the way into May, and so we've had a reasonable number of kidney transplants. I'm about to do my 7th of the month later on this afternoon, and my colleagues have been doing them also. And the liver team has gotten quite busy. So the things that have been implemented over time is that routine COVID testing of deceased donors was implemented in the middle of March. And then routine recipient testing has been implemented immediately prior to transplantation toward the end of March. Originally, this was something that could take 12 hours, so we would be bringing in recipients very early. But as the number of patients has declined, the turnaround time for the COVID testing on the recipients has also declined, so that yesterday, late afternoon, early evening, we were able to get turnaround time of about an hour for COVID testing on the recipient. There have been now a few patients who have been transplanted having recovered from COVID and becoming negative for COVID testing at the time of transplantation. Some of our patients who were being called in for transplantation had to be deferred because they had active COVID infections and hadn't quite yet recovered. We haven't yet reached a point where we're going to be willing to use deceased donors or living donors who have had and recovered from COVID, but that's probably going to be coming up at some point. Within our own kidney transplant population, there have been a small number of patients transplanted during this time frame who have developed COVID infection. We aren't certain whether it was nosocomial or whether it was donor transmitted. We suspect. Now in May, we've gotten busy again with deceased donor and living donor kidney transplants, deceased donor liver transplants. All of our recipients get COVID testing immediately prior to transplantation. The living donor patients, recipients, and the donors get tested the day before surgery. And we have a COVID-free floor where patients are hospitalized. So it sounds as though, even though New York is still problematic, we've gotten back involved. Some of our patients who have been transplanted have had COVID infections and then recovered from them and then come in for a transplant. Some have had to be put on hold because of COVID infections. So there's there's risks for patients who remain on dialysis getting COVID in their dialysis unit. While New York is still mostly shut down, we're moving forward with transplants. and are hoping eventually that this will all become sort of a nightmare in the rearview mirror. But in the meantime, we're moving forward carefully with transplants. And I apologize at this point. I'm actually still on call for kidneys, and they're calling me about organ offers. So I'm going to have to sign off now.
Thank you very much. So really, I'm obliged. Thank you so much, Dr. N. Shapiro, for a nice giving us the knowledge and experience of yours and the New York and transplant. Thank you very much, Dr. N. Shapiro, joining us.
All right. Bye-bye.
Thank you. Thank you. Bye-bye. Now, I will invite Dr. Deepali Tewari. She's a faculty, New York Medical College, Division of Pediatric Gastroenterology and Hepatology Diseases. She will share her experience. Dr. Deepali, please.
Thank you, Dr. Tomar. And I hope you all are able to see me. Can you?
Yes, please. Yes, please. Yes.
Okay. So, good evening to my Indian fraternity and greetings to all my friends across the globe. It is again an honor to join you all back. We met in 2016 with a great conference, and now this is the second time we're meeting again. But this time we are discussing a very grim topic, which is it's a very sad topic to discuss personally for me, because I am a New Yorker, and New York is the hardest hit with this tragedy. As you can see, this is the globe and presentation of the COVID-19 patients, and the hot areas are all the red zones showing the excessive presentation of COVID-19 here in United States. In New York State, we saw a huge spike in the mid-April, if you could see the graph. But luckily now, thankfully, the number of new cases in New York State is declining. And this is the graph which shows the states in New York City. And in New York City also, there was a big spike in the middle of the April. And now, again, the number of cases are going down. We're talking about new cases we're seeing every day. This is the New York City boroughs, and the highest hit borough in New York is the Queens and the Brooklyn. The reason being is that these areas are very densely populated. So that's why the spread is rampant over there. This is the graph which presents the New York State hospitalized patients. So if you see, this is a blue chart, which is on the top, which shows you New York State condition, and the red shows you New York City hospitalized patients. So if you see here, the New York State again peaked in terms of hospitalized patients, and also the peak we saw in the intensive care admissions, which is declining for both New York City and New York State. Now, this is the saddest slide here, which I'm presenting today. If you see, the number of deaths have been climbing gradually, and we are approaching the mark of 25,000 deaths in New York State. This is the new deaths. So this is a total death, and this is a new death. So we saw a peak, which was approaching more than 800 cases in New York every day. And now we are down to less than 100 on a daily basis. Still not a good thing to say, because the people who are losing lives, their families are sad, but still it's a better mark compared to where we were a few weeks ago. This is again the graph predicting the New York City deaths. That was New York State, and this is New York City itself, a small area with a huge number of deaths. And these are the daily deaths. If you see, there was a spike again in the middle of the April, and the count of the daily deaths has been gradually declining as of today. By age group, we have seen the highest number of patients were in the range of 65 to 75 years of age. Overall, the case fatality rate was 10% death rate, but in the patients above 75 years of age, it was more than 40%. Now, this slide shows us that the patients who had underlying illnesses, they were the highest hit, whether they were above 65 or above 75. If you had an underlying illness, the chances of having a poor prognosis was high. This slide shows us the comparison of the people who were involved on the basis of their race and ethnicity. And we have noticed among the death patients that the African Americans and Hispanics were the highest hit compared to the white and the Asian population here in New York. So in children, as of now, only 1.7% COVID cases are recorded, and the age distribution among the kids below 10 years is 15%, and above 10 to 18 years is somewhere between 27 to 30%. New York has around 100 cases of the children with multi-system inflammatory syndrome, which is linked to COVID, and I'm involved in care of these patients on a daily basis. 5 children, unfortunately, have died due to MSIS, and 2 of them are in our hospital. So what is MSIS in children? It's a rare but serious condition which is associated with COVID-19 and is reported in children. It mimics Kawasaki disease and a toxic shock syndrome, which includes fever, hypotension, GI symptoms, rash, and myocarditis. The rate of ICU admission can range in these kids up to 2% if the kids are infected. So the question is, where are we now in New York? Now the pandemic still continues. We're not over yet. Suppression has been achieved in some areas, but the outbreak is accelerating in others. Since the first confirmed case of COVID-19 in New York, over 23,000 deaths have been attributed so far. We had a peak in April. We witnessed a decline since. The preventive measures, including physical distancing, are working as it appears. So what's the goal? Our goal right now is to save lives, resume economic activity without igniting dangerous new flare-ups. Restoring the economy and health of the nation, both are priorities. We can't ignore and neither can be dismissed. So we have a bigger challenge ahead of us. We all have the will. We do not have the way, not yet. We do not have an effective vaccine, maybe a year, which is very optimistic statement. Treatment drugs are there, not available so far. Large number of people are spreading the virus across without showing the symptoms, which is a big concern. So that requires to test millions of people so we can identify who are sick, we can trace their contact and isolate the ill to stop the spread. We are limited in terms of the testing kits, and we are limited in terms of PPE, and the key supplies are short. Then we are also facing job losses, which is appalling, and essential workers like myself and the healthcare workers are exposed to viruses at a very high rate. What's happening currently? We are trying to develop a quick diagnostic test, which resembles a pregnancy test, so patient can test themselves at home. And this test likely will be available in a few months, where you swab yourself and check on a strip of paper. Then the phone applications are coming up. If someone is positive and people choose to install this application, you can know if you're traveling somewhere who is positive around you, and you can take certain precautions. We have been using convalescent plasma in the patients who are admitted with COVID in our hospital. It is promising, but it hasn't been shown to be completely safe and effective as a treatment. So our labs are trying to identify the antibodies which are effective against the virus, and then manufacture these antibodies to be used in other patients. Also, there is an RNA vaccine which is under trial, but again, it's a hope that we'll have it by next year. We have multiple ongoing trials where our hospital is involved too. There is a big trial going on by WHO, which involves 4 arms. One is remdesivir, the anti-Ebola drug, hydroxychloroquine, lopinavir, and lopinavir with the interferon beta, which is a drug for multiple sclerosis. There are multiple other drugs under investigations, as we all know. NIH and Mayo Clinic is also running a trial. The biggest question lies here is about the hydroxychloroquine, and there's a lot of media discussion about hydroxychloroquine on Facebook, Twitter, etc. So we had a larger study conducted at Columbia University right in the heart of New York, and that included 1,376 patients. Out of those patients, 811 patients received hydroxychloroquine and 565 patients did not. So what did the study found? That the patients who received this chloroquine had the same risk of intubation and death as the patients who did not receive the drug. So the researchers have concluded that hospitalized COVID-19 patients should not be routinely treated with hydroxychloroquine. We have not been routinely using hydroxychloroquine in our hospitals in New York, and we require bigger trials. Having said that, WHO on May 25th put a pause on hydroxychloroquine arm in their trial because it was giving some side effects. So what can be done at this point? Social distancing to continue perhaps for months. We should continue to wear masks, attend the video meetings like we are doing today. Keeping 6 feet away, grabbing takeouts, and avoiding the crowds must be an accepted part of the daily routine. For sometimes, these tactics have successfully flattened the curve for us in New York. Realistic and persuasive road to economic recovery is important. We have to be clear and transparent, control the disease, and restore a sense of safety. On top of it, we should share our experiences honestly and learn from each other's mistakes, which is what Dr. Tomar has arranged today. So the projections, what will happen next in New York? There are multiple models now, but we are following the Institute for Health and Matrix Evaluation model. They are predicting that by the end of July, we will be seeing around 32,000 deaths in New York here, which is sad. We are already at the mark above 23,000. But by July 1st, if we continue to keep all the social distancing and the preventive measures, we may be able to bring down our chart below zero. This is the death rate projection for USA, and the previous one was for the New York. So as if you see here, in United States, the model is predicted that by August, our death rate may be between 120,000 to 180,000, which is a very sad scenario. So at the end, I have to say, we are all in this together. Thank you, Dr. Tomar and the team for this initiative. Stay safe, stay healthy, you all, and have a blessed life.
Thank you, Dr. Tewari. Thank you for very elaborate presentation. Thank you so much.
My pleasure. My pleasure, Dr. Tomar.
Thank you. So now I will invite our next speaker, my friend, Dr. Jay N Shah from Nepal. Excellent. He is a president of Patan Academy of Health Sciences, Nepal. He will present Nepal experience. Dr. Jay N Shah, please.
Okay. So good to see you all again.
Yeah, thank you so much.
I'm Dr. Shah from Nepal, Kathmandu. I just wanted to recap what we met 4 years ago.
Yeah.
Some beautiful slides over there and some good time we had. And
yes, please. Nice.
Yeah. So nice. I'll just basically discussing the overall scenario of my university here and what we are doing in overall in Nepal itself. So this is my university hospital in Kathmandu. So what we see over here is, from the government side, what they have done is they have designated hub hospitals and satellite hospitals. And my hospital is one of the hub hospital in Kathmandu. So we are very much in this scenario, and we are a dedicated hospital for COVID itself. So what we see this is going back to January, end of January. We had one publications that time, and what we saw by the end of January was the government has taken initiative to designate the hospitals, like 5 hub hospitals, satellite hospitals, and the Ministry of Health and Population. They started high-level meeting daily and then briefing. So this went on very okay. This is a slide from yesterday, and this is I took it from the Viber group, which is shared by the Ministry of Health and Population. And what you can see over here is the upper part, that's the yellow one. We have now almost about 60,000 tests done. And out of that, we have 1,000 positive cases. This was study data. Today, we have added 200 more. Out of this, till now, we have 5 deaths. And there is still almost about 90,000 people in quarantine itself. But what is interesting is what we see over here, the graph over here. The first case was in January 23. And it was very interesting that time that I left Kathmandu on same day for Shanghai to see my daughters over there in the peak time over there. But you see, by the January 23, then coming to March 23, in 2 months' time, we had only one case in 2 months. By March 24, the country started to decide on lockdown, March 24. But what we see in this 3 months' time is by May 28th, that yesterday, it's almost about 1,000 times positive cases. So that means that even after lockdown of 2 months, by March 24 till May 28, we're still in lockdown. Seems like something is not really working. So what we have done at the hub hospital and designated hospitals, what we are doing is, as for example, this is my hospital over here, and we have established a incident command system, which is mainly 4 arms: the planners, the orientation communicating officers, logistics, and then finance. And all under this, we are, for the last 3 months, we have been functioning till now pretty okay. What we do in our hospital university is we have daily hot briefing in the morning, at least twice a day, morning and afternoon. Then we have all the department chairs. We meet daily in the afternoon. And then we have a committee meeting again once a day. So this means like we are quite busy in every day modifying our system, modifying the way we work. Same goes with the planning system itself. We have at least 3 plans now. So what we are doing is plan A is already not working now. We are in plan B. That means that we are functioning as a dedicated hospital. One wing is completely dedicated to the COVID. And then again, we are seeing the normal patient as well. We are in plan B right now. Plan C is basically when there will be a surge in the cases which we haven't seen yet, and that time probably the whole hospital will be shifted to the COVID care. What we changed in this scenario is, like we have established 2 double triage system, the primary triaging and secondary triaging. So that helps us to streamline the patients who are suspicious. Then they go for the second triaging, and then they go for the isolations and all these things. So this has probably saved us. Till now, we have not even a single health professionals infected till now. Hopefully, we'll continue like that. This is in-house because of shortage of the PPE and equipment. So what we have done is we have our inbuilt in-house production of PPE, which is not as good as commercially available, but it has helped us in the scenario itself. And then this is the training we do for the staffs who are in COVID system, donning and doffing, then intubations. This is all. At the same time, what we have done is we have dedicated plan and system to have a fever clinic. Then we have the plan for COVID isolation itself, COVID ward itself and ICUs, and COVID OT. So we have different OTs which is functioning as a COVID and non-COVID as well. But what we see right now is at our center, and probably this is maybe more severe in other centers as well, we have not very large supply of the logistics. Quarantine for the staff who are respected, and then the healthcare service itself. So we also have done our in-house quarantine itself. The people who are suspicious of taking care of the patients they stay in the hospital itself in quarantine. And 3 days ago, we had a positive case of RTA, road traffic accident, who was successfully operated for both leg fractures. What we have done also is, because I'm overseeing this journal at our university, so in the last issue, we had almost about 75% of the articles published only on COVID, and all basically done at our center. So this is also what we have been helping ourselves and other institutes in the country itself. And this is very good that the Ministry of Health, they are taking our advice the way we have been working at our center.
Well, Secretary.
The bad part, what is the serious part over here is, like say, very frequently in Kathmandu itself and outside Kathmandu, what we see is lots of hospitals. They get positives and they are sealed off. So this is a created problem that service is furthermore hampered on this way. The other problem of what we see is after the lockdown, people have not been able to return to the country. What you can see over here is people, especially people coming from our neighboring borders, from India, Bihar, that lots of people are stuck at the borders. They are very in pity state, and this has been still going on. And we also had 2 days ago death in the quarantine and the people at the border itself. So this is probably the big problem that we have been facing. It's out of control, probably not working the lockdown measure itself. So that's what we see is what we on the surface that last almost 2.5 months during lockdown, it looks pretty okay, but on the surface, lots of problems are there. I think, thank you. Very brief.
Thank you very much, Dr. Jay N Shah. Thank you very much for your giving experience of Nepal controlling the COVID. Thank you so much. Our next speaker is Christian Juton from Cameroon. He is the president of the Douala Medical School of Cameroon. Dr. Christian Juton, the Cameroon experience, please, on COVID-19. Please continue.
So this is the Cameroon experience. And I was saying that we have a lot of difficulties regarding the fact that we are in four countries and we are facing a lot of difficulties in this fight against coronavirus. Anyway, we are trying to do our best, and you know that Cameroon is a Central African country, the most important of the Central African region, and this is a map of Cameroon regarding the statistics in our different regions. The main cities are the place we will find a huge amount of infected patients. That means Douala, which is the largest city in Cameroon, is the economic capital, and Yaoundé, the political capital of Cameroon. So this is the place we find a lot of positive cases. This is our statistics to date. We have about 4,800 confirmed cases in our screened patients, because we still have a lot of patients we cannot reach in order to screen them and to test them. But we think that the amount can be higher than this one. And in this amount of patients, we have about 41 cases under intensive care. And to date, we have about 177 deaths, so that the lethality rate is 3.7%. And we have confirmed that 1,900 patients are healed, actually. And I insist on the fact that this statistics is a bit underestimated. We should know that in reality we can have a bit more than that. This is the evolution of the cases of COVID-19, new cases in Cameroon. You see that since the beginning of the pandemic, things are rising tremendously after days. And today, to reach the amount I told you previously. So you see, this is a regular statistic we earn from the Ministry of Health, And you see this, the problem is huge. We have not reached the peak actually, and we are waiting for that. So you see that when you are going to reach it, it will be a very serious problem. We must insist that we don't have as much cases as the provisions, because you know that we don't know the reason to have this BCG immunization and so on, but the real cases on the field is still huge, considering the number I told you. This is how we proceed for screening. Everybody arriving in Cameroon actually is to be screened, and all positive are going to be confined for 2 weeks. And actually, normally our borders are still closed. And also, we try to screen contact persons. You know, in our setting, it is difficult because the population is not clearly located in cities. So when you have the name of the person, to find him is very difficult. So anyway, we try to have some, and we reach a lot of contact persons so we can screen. And in case of positivity, we confine. And also, everybody who attend our consultations in special hospitals with some symptoms are to be screened and confirmed, and so we take care of them. About the screening facility in Cameroon, we have 10 regions in Cameroon, and in each region we have 1 to 4 screening centers per region. The most important number is in large towns like Douala and Yaoundé. It is not still enough because the population is very crowded in these facilities, and they can wait 2 to 3 days to be screened. So this is a big difficulty. Or we must try to see how we can screen a lot of persons, because this is one of our challenge. I am going to come there afterward. The main thing used for testing is, of course, polymerase chain reaction. Mainly, we use that in Cameroon for this large screening. How do we manage the patient's positive cases? It depends on the situation and the stage of his illness. Generally, people with not a lot of symptoms are confined at home and treated. And some in bad conditions are hospitalized and maybe in resuscitation rooms and so on. But the main problem in our setting is that we don't have a lot of equipment. We need some more equipment to take care of the patient we can receive in our different hospitals. And in large cities, we have 5 to 6 general hospitals with enough equipment, but a little bit more should be necessary. And in small city, we have only 1 or 2 main hospitals who can try to take care of these patients, but there is a lot of things still needed. And also, we are going to integrate private clinics in the follow-up of these patients, because the public system is not going to be able to take care of all this large amount of people infected. The main treatment we use here in Cameroon is free, and it is still chloroquine. Although they are criticizing this treatment, we still use chloroquine plus azithromycin in many cases. And necessary oxygen and so on in resuscitation centers, services. Some other associations of antibiotic can be used from part to part, but mainly we use chloroquine and hydroxychloroquine with azithromycin. We try to have the analysis, blood test and so on, and scanner at the lowest cost we can reach, because we are very we have a population very poor, and they cannot afford these exams generally. So the state is trying to have this free or at a very low cost, so that we can continue to take care of these patients. In Africa, of course, I must say a few words about the traditional approach. This is a big problem in our setting because you know that we mostly trust on natural healers, and in this case of coronavirus, they have increased in numbers. There are very, very great number of traditional healing saying that they can take care of COVID-19. So they give many mixtures with plants and herbs in very hot waters. What we know is that we have a lot of consequence of this sort of natural treatment because you see this, the composition, the component given in these mixtures are very aggressive regarding the digestive tube and also the liver and kidney. So we have these patients with side effects of this treatment. Many severe digestive lesions, and generally in the stomach with ulceration and gastritis, very severe. With some of our patients have hematemesis and so on. And so that is very important. But some patients have liver toxicity with the transaminase rising a lot and some beginning of kidney failure. Regarding the success of this traditional treatment, this is to be demonstrated because to now we cannot say that it can help or it cannot help. So we know that in our countries, the national politic is to collaborate with traditional healers and so on. But the problem is to concretize the results and the success of this treatment. So we are still waiting for demonstration and for results. Our challenges now. Of course, I told you we have to switch to general sensitization and mainly mass screening because this is one of the ways to try to stop this pandemic nationwide. Because why? Because if we don't screen all positive cases and confine them, we cannot succeed in this fight. So we have everybody positive has to be confined 2 weeks, and after that, the PCR can confirm that he is healed and he can be free. We also advise to generalize the wearing of face mask. This is one of the best things to do and to insist on. Of course, we must have a free mask available, if possible, or affordable prices. So we have the state encouraging fundraising in order to buy this mask and also hydroalcoholic solutions. And in the sensitization, we insist on the population to have the habit to wash their hands very often as possible. The other problem of this in our poor economic system is to try to find out how we can compensate the economic consequence of this confinement and so on. So the state is studying that, but for now they have not taken a big decision, and so the poor population is in a problem, has many difficulties. So it is an emergency to see how to help them. As I told you, our health facility is not as good as possible, so we still need more equipment in our health facilities, so we are more prepared to help all these patients. The countermeasures used in prevention of these pandemics is the one used in the entire world, of course. We have chosen the partial confinement because the structure of our society is difficult to make total confinement because to follow that is very difficult. So we have tried to confine some main cities and some population in these cities and markets and things that is very difficult to close our markets here. We saw in some countries succeeded, but here in Africa it's difficult to close markets and so on. This is not good, but we have difficulty to succeed in that. The social distancing, of course, is recommended. Also difficult because I told you we cannot close strictly all markets and this market still functioning, you cannot obtain social distancing very good in those markets. But we have succeeded to close a lot of public places, like market is partially closed. But bars, schools, and university are closed till now. And we are going to still remain closed until June, I think. All public and crowded manifestations are forbidden in Cameroon. Maybe funerals and so on, all sports and so on. I told you that we advise to wash one's hands often and hydroalcoholic solution and general hygiene of course. I will talk about face masks. And we are going to think about in a few weeks how we can deconfine progressively. And of course, at that time, we should have reached the mass screening I was saying previously. Thank you very much.
Thank you, Dr. Christian. Thank you very much for your nice, elaborate presentation regarding Cameroon COVID experience. Thank you very much.
Okay, my friend.
Well, Dr. Marina Orsi, I will take before you now for very 5 to 10 minutes, Dr. Abdul Rahman Hamid, who could not join, now he's there. So I will request now Dr. Abdul Rahman Hamid, please join from Afghanistan. He's the Vice Chancellor of the Gulf University of Afghanistan. Afghanistan share.
Yes. Yes.
Now, Abdul Rahman Hamid, please share.
Yeah.
Seeing and listening you. Please continue.
Good evening, Dr. Balvir Tomar Singh. I'm really happy to see you again after February 2016. I'm Dr. Abdul Rahman Hamid from Afghanistan, Ghalib University. I'm the Chancellor of this university. I will share my experience, challenges, countermeasures, and prevention of pandemic COVID-19. First of all, I would like to share the memories of NIMS Jaipur, Rajasthan. You see now here the picture of me. This is me. This is Professor Balvir. This is me. These are my colleagues from Afghanistan here.
Yes, very nice.
I hope
very
you.
Nice to see memories. Very
Thank
nice.
you.
Thank you.
Thank you. Dr. Balvir and other presenters in this conversation and this meeting.
Okay.
Every first confirmed case of COVID-19 was a 35-year man in Herat city, which is the west part of Afghanistan. Here you see in the map, and it was on February 24th, and it was a person who recently traveled from the Qom province of Iran to Afghanistan. After that first positive case, Ministry of Public Health and the government formally announced the travelers coming from the outside country, especially from of Afghan young refugees was back to Afghanistan from Iran. As of May 28th, today, we have 13,036 positive cases in Afghanistan. From these cases, 1,209 are recovered, 235 deaths in all 35 provinces of the country. Kabul has the highest cases, which is more than 5,000, and the next is Herat province, which is 2,000, more than 2,000, and then Balkh province, which is at the northern side of the country, Afghanistan. And then Kandahar and Nangarhar are the largest cities with the lesser positive cases. And according to the research, there are 8% of total confirmed cases are among health care staffs. And we have some from healthcare staffs also in my country, which is more than 25 cases of doctors. And the majority of the cases, these are the average ages 40 to 68, 69. And fortunately, we don't have any children are affected with COVID-19 in Afghanistan. Here you see the graph from the beginning on 24th February to 28 until today. And you see here the graph is gradually increasing, and we are now at the peak of the positive cases in the country. You see here the crowd in Kabul city, though the government has started to lock down, but the people, because of the holy month of Ramadan and then the Eid celebration days, they break down the lockdowns. And the important news from our country, this is the picture of Ministry of the Public Health. He was also affected or infected with COVID-19, and right now he's okay. If we compare Afghanistan cases with some countries like Iran, India, and Turkey, the graph is much different from these countries. If you see the graph from Turkey, the incidences are rapidly growing up, and then it is now the same like in some other countries. But if you compare Afghanistan, that the incidence and the positive cases are much lower than other countries. If you compare this with Iran, and Iran is also, the graph is has increased rapidly, and now it is under control in Iran province. But still in Afghanistan, the graph is very slow and gradually increased. And if you compare with India, it is also the same as other countries, but Afghanistan is still growing very slow. So, according to our experience, one of the important experience was the urgent lockdown and quarantine by the government. And there was another policy from Ministry of Public Health, which is called fear policy. Ministry of Public Health was announcing that, be at your home, stay at home. If you come out, you will be dying from the COVID-19. So there was a very fear policy against the people, and the people were all locked down themselves inside their homes. But after a few days, the lockdown was broken by the people. So there was some reasons which I will explain. A rapid closure of schools, universities, restaurants, public gatherings, public areas was also another reason or another experience of our country, which allowed us to control the COVID-19. And another experience was some companies started to make face masks, PPEs, and some donations of from other countries like China. They donated masks to Afghanistan healthcare staff. Some volunteers distributed masks among people on the public, and also some volunteers made some ventilators which to produce RT-PCR kits in Afghanistan. And now we are announcing that we have kits in our country. We don't need now kits outside the country. We have time PCR kits from inside the country. And there are some reasons that why we had low death rates reasons. One of the important reasons is life expectancy. The life expectancy in Afghanistan is 64.96, according to 2020 reports. And this shows that the majority of Afghanistan population are young generation. And also another reason is a rural population. Lots of people, more than 45% of people are living outside the cities. They are living in villages, and in villages they are using the natural and organic sources from the food. There are maybe also these kind of reasons, maybe the reason of low date reasons. And also the lifestyle of the people. All of Afghanistan people are preferring to use organic foods than other foods. And sometimes people or some medical staff are saying that BCG vaccine. I have read some papers regarding the BCG vaccine, that these days in Afghanistan, lots of children are getting the BCG vaccines, and I don't know if it has the effect or no. Then there's an
मोबाइल से कनेक्ट किया हुआ है उन्होंने
against common infections, and there may be another reason that hiding these caused and they are not reporting from the people, and they are not going to publicize these kind of deeds. They are hiding their deeds. There may be another reason, and also low testing rates. We had very low testing ability until now, and the maximum testing per day was 1,000 tests per day, and it is very low, I think, to compare to other countries. And the challenges, we had less tests per day, as I mentioned. The people had no trust on the healthcare system, and the government. Even it is very important. It is very interesting that I can share with you that still people in Afghanistan are not don't believe that there is a disease like named COVID-19. They think that it is a publicity. It's a kind of political game. They say that there is no COVID-19 in Afghanistan. And you see there are some pictures of healthcare staffs and some gatherings, and here a shocking gathering of Eid days. There's a picture of 2 or 3 days before Eid celebration. And some countermeasures from our country. We had increased awareness through public society, through social media. We distributed food to poor people, and there was some marks inside the distributing the food and bread. There are some people staying there and inside a place which are bakeries providing food and bread for the people. There are some testing from the border from the Iran, which is and there are some female healthcare staff testing, checking the pressure or temperature. And there are the crowd of people are gathered to get the food. There are poor people get the simple bread from the bakery. And there was fear policy. There was a good experience from our country, and continue the lockdown was another good experience. But there were some challenges. Helping poor population had some gatherings, and social distancing practice was not much. People were not much familiar with these social distancing practices. And there was another challenge with another good experience in our country, which is herd immunity. We think if we let the people be infected and then get the immunity, we will get the herd immunity as soon as possible, and that will be a good chance for eradicating these COVID-19. And even the Taliban, the opposite people from the government with the had also some gatherings, some announcements, some social media experience from these people also we had. And the good news is that these days there are some hope that they will, the Taliban will come and share and then come to the negotiation and will talk about the peace in Afghanistan. And we hope so. And there's a my last presentation. This is the social distancing, nice picture, which we put on the social media in Afghanistan. There's the choice is yours. You should keep the social distance 6 feet, or you will keep another distance underground. There's a thank you for from your nice hearing, and thank you all. That's my all presentation, which we shared about Afghanistan experiences and challenges and countermeasures. Thank you. Thank you, Dr. Balvir from your nice conference. Thank you.
Thank you, Dr. Abdul Rahman Hamid. Thank you very much for sharing the Afghanistan experience of combating the coronavirus infection. Our next speaker, I will invite Dr. Marina Orsi from Argentina. She is a Chief of Pediatric Gastroenterology, Hepatology and Transplant Unit and past President of ISPGHTN and of Latin America Society. So I will invite now Dr. Marina Orsi from Argentina for sharing her Argentina experience on COVID-19. Please continue.
So thank you for the invitation. I think really this is fantastic to put together people from so different environments. So thank you for this. I am talking now I'm going to talk about Argentina. This is what the situation in the Americas. Now the COVID-19 has come into the Americas and South America. As you see, is with great impact. And here you can see some of the South American countries, particularly Brazil, Peru, Ecuador, and Chile, and Mexico in some sense too, have a quite important impact on this deaths and the prevalence of COVID-19. What is happening in Argentina that is part of South America? I want to let you know some data that perhaps are important, why this impact is a little different. Argentina has a fairly high proportion of seniors over the age of 65 who account for almost 11% of the population, although 26% of the population is under 15, which is slightly lower than the world average. We have 44 million inhabitants with a birth rate of 17 every 1,000 and a growth rate of 1% and 7.39 deaths per 1,000. What is our reality? On March 3, the first case was confirmed in our country. And yesterday, a total of 40,702 people have been infected. 6% are reported, 43 close related, 34 for community circulation. 31 cases over 1,000 inhabitants and 4,349 recovered with 500 deaths. That gives a mortality rate of 3.59%. On March 19th, we entered into a nationwide lockdown. And this, that is quite hard for everybody, helped all the health system to really prepare all the hospitals to be in a more convenient way. So the lockdown was lifted out throughout all the country on May the 10th, except for the city and the province of Buenos Aires, since this lockdown is expected to continue at least June the 7th, because a big jump on new cases was observed in those areas. Which were the responses to the outbreak? What it included: restrictions on commerce, movement, close of all the borders, schools, and all educational and sports institutions. Clusters of infections and deaths have occurred in nursing homes, prisons, and particularly on the more crowded urban areas. Here you can see what's the mortality rate and the incidence rate of Argentina in relation to other countries in America. This is our, since it became how is growing up the infection, the testing, and the death rate. Here I want to state what is the real problem and where we have to focus, and we are focusing our problems. Almost 1/3 of the population of Argentina lives in the city of Buenos Aires and the province. These areas, the city has very modern and very nice neighborhoods, but as in many other big cities, the surroundings of the city have more poorer neighbors and more crowded neighborhoods. And this is where the problem with COVID-19 has raised our alarms, since here is where we have the most cases and the most problems. This is the city of Buenos Aires, and this is the province of Buenos Aires that is mix of a rural area together with an industrial area, but also the city of Buenos Aires, there are poorer neighborhoods where now we are having problems with high numbers of COVID infection and problems with the circulation of these people. One of these environments has been locked down by the government so that they cannot circulate to try to avoid that this spreads all over the area. The government has done a big effort to help the poorer people, giving help in terms of a card to get food and some help in terms of money, so that the poor people that are not in the labor system and have some income and be in a better way to in these times. What is the situation in our intensive care? Intensive therapies are at 50% of their capacity, and that put us in a more comfortable situation, both for health personnel and for patients. The province of Buenos Aires has already completed a provision of 1,000 intensive care beds for adults and has recruited 1,300 professionals, all residing in our country, implementing a computer system that will include all the available in each province and beds in use in real time. Another achievement of social isolation, giving Argentina science time to develop diagnostic kits, both genomic, faster than conventional PCR and serological. The early lockdown allowed to improve and adjust the health system in terms of private and public in the capacity in intensive care units, ventilators, sanitary protection, and also testing. In fact, the number of critical care beds was estimated for the entire country about 8,500 for adults and 1,600 for pediatrics, and nowadays 1,000 more have been added. At our hospital particularly, we had 120 critical care beds for adults, and we had increased 200 to 250, and the ventilators went up to 169. This time gave us the opportunity to increase supplies and reorganize ourselves. This is my hospital, and the death in my hospital have occurred in more elder patients. It's 89 instead. The media in the country is 75 years. And we did a great effort to sectorize all the hospitals so that patients don't cross with very sick patients that have to go, the same have to go to the hospital.
Dr. Orsi, we are running out of time. Please, a bit fast. We have to complete.
Please. Okay. More than 85 of the country departments are in a favorable situation in a scheduled reopening, Active testing is helping to quickly identify cases and establishing measures in the confirmed people. So I am going to go a little faster and talk about what is happening with pediatrics, and that I think is our group and our risk group. And so I am going to share this last one, the prevalence of COVID in children under 18 years. And these are data from May. 11% of total cases were under 6% of tested cases, 8% under 1 year of age, 63% between 1 and 12 years, 15% in between 13 and 15, 36% over 15. Public health was accounted for the 76% of them. And as you can see, most of the patients, pediatric patients, also lived or in the city of Buenos Aires or the province of Buenos Aires. And most of them came from vulnerable neighborhoods, comorbidities, or had been in institutional nursing systems. Only 2 cases needed intensive care treatment, and there were no deaths. So until May 28th, no child or adolescent patient was seen or admitted with confirmed COVID-19 having a chronic gastrointestinal or hepatic disease, neither in those with hepatic or intestinal transplant in Argentina. My last thoughts and challenges: patients and medical staff feel fear and anxiety with this pandemic. We need to look after both with adequate, safe protection. That is a major issue. Health professionals have a key role in this situation. Quick sharing of investigation results of our daycare work is of capital importance. Areas with social inequity and human clustering are at major risk. So we have to focalize with critical points and establish quick, cheap strategies. That is essential. It is only with global efforts like this meeting, through scientific societies, that we can really impact and have safe, health, convenient policies to overcome this COVID pandemic. Thank you. It was really a pleasure to share all the previous conferences and to able to share the Argentinian experience. Thank you.
Thank you, Dr. Marina Orsi. Thank you very much for a very nice, elaborate presentation regarding your experiences in Argentina. Thank you very much. Now I will invite our next speaker, Dr. Erkin Yakubov from Uzbekistan. He is a COVID-19 Core Committee, Ministry of Health of the Republic of the Uzbekistan.
Good evening, everyone. I am Dr. Erkin. I am from Uzbekistan. There you can see my introduction. Detection of the coronavirus in the Republic of Uzbekistan. Implementation of operational quarantine measures in the Republic of Uzbekistan. Assistance to patients and low-income population during the quarantine period in the Republic of Uzbekistan. Detection of the coronavirus in the Republic of Uzbekistan. According to the Ministry of Health of the Republic of Uzbekistan, the first of COVID-19 in the Republic was diagnosed on March 15. A female patient was tested positive for COVID-19 after returning home from France. Implementation of operational quarantine measures in the Republic of Uzbekistan. President addressed people in connection with coronavirus situation. On March 18, the President of the Republic of Uzbekistan, Shavkat Mirziyoyev, at the video conference devoted to the issues of Mahalla and familiarized the problem of coronavirus spread in the country. Quarantine measures. There you can see a number of pictures. At the initial stage of the spread of the epidemic, on behalf of the President, a special Republican Commission led by the Prime Minister was formed. As the result, mass penetration into the country and the widespread of disease were prevented. Holding public events is limited. Starting March 18, students from all education institutions were sent on vacation. Medical facilities are transferred to a special mode of operation. Sanatoriums and children's health camps are adapted to work as quarantine institutions. Compatriots who have gone abroad on business trips and on the affairs are returning home with charter flights. Traffic at the border is limited, but tracking has not stopped. Every day, many foreign and local carriers enter and leave the country. Assistance to patients and low-income family population during the quarantine period in the Republic of Uzbekistan. For the first time in the world, a quarantine zone hospital for 10,000 beds was built in 5 days. Call center opened for the purpose of systematic work with address of the population and rendering of the address health works regularly. During the quarantine period, practical assistance was provided to the poor. 16 types of primary consumer goods were delivered to low-income people and pensions. During the quarantine period, workers were paid in a certain amount of money. There you can see a number of pictures which related to helping humans. Doctors who worked with patients were awarded $2,500 and nurse $1,500. The state allotted $3,200 per day to each of the treated patient. They allocated $200 per day to each of the quarantine patients. The state allotted $250 per day to each of the rehabilitated. School children and students continued their education online during the forced vacations. Broadcasting of video lessons was organized jointly with the national television and the radio company of Uzbekistan. The classification of regions according to the level of quarantine was introduced in the country on May 8 in areas where the infection was not detected or patients fully recovered. The level is green. Where the virus has not been detected in the last 40 days, but patients remain yellow in the region where cases of infection are recorded, red. The quarantine level will be revived on the development of the situation. To date, 3,200 people have been infected in the Republic. 2,700 have cured and 15 people have died. Conclusion. In conclusion, I want to say that the correct and timely policy pursued by our government has minimized the spread of COVID-19 pandemic in our country, and our country has become the last affected republic in Central Asia by the COVID-19 pandemic. Thank you very much.
Thank you very much, Dr. Irkin Yakubo. Thank you very much for sharing your Uzbekistan experience regarding COVID care, COVID competition, COVID killing. Thank you very much.
Thank you very much.
Now
Thank
I
you, Dr.
invite my
Tomar.
next speaker, my dear friend, Dr. Johnny Ludvigsson from Sweden. He is Senior Professor of Pediatrics, Crown Princess Victoria Children's Hospital, Linköping University Hospital, Linköping University, Sweden. Dr. Johnny Ludvigsson, please.
Yeah, my name is Johnny Ludvigsson from Sweden, and thank you very much for this invitation to participate. Sweden has a quite different approach than most other countries, so therefore it may be of some interest for you to hear what we do in Sweden. We have rules. Some countries believe that we don't have any rules at all, but we do have rules, but they are recommendations. Stay at home when people have symptoms, wash your hands often and more than 20 minutes, keep physical distance, and not more than 50 people together gathered. Avoid larger activities like weddings, parties, funerals, and so on. And do not travel at rush times in the underground buses, trains, and so on. Cancel or avoid unnecessary journeys. And people who are older than 70 years are regarded and are well known to be vulnerable, and therefore they should keep the rules carefully. If possible, be isolated more or less, but assisted isolation so they could get help, of course, to get food and everything like that. But they should not meet people indoors, they should keep distance outdoors. The high schools and the universities, they have education at distance. They don't open until the 15th of June. Senior sports have been cancelled, like senior football, soccer, that sort of senior sports. It will open again in the middle of June. Concerts, music events, theaters are closed unless they can keep, it should be less than 50 people. And people work at home when possible, otherwise they go to work. We are not supposed to travel more than 1 to 2 hours away from home unless necessary. Visits at homes for elderly is not allowed. And we are not supposed to travel abroad, of course. These are rules and recommendations. There is no laws saying this. There is no police or no military force. It's building on confidence in society and personal responsibility. This means that in Sweden, in contrast to almost all other countries around us, we have not had any complete lockdown of society. Everybody is allowed and are even encouraged to be out, walk, visit parks, and so on, to be active, but keep distance. Even and also older people are encouraged to be out, take walks and so on, but keep distance. Everybody is allowed to work, have been allowed to work all the time. Go to work if they need to go to work, not people above 70 years of age, of course, but otherwise they can go. If they can work at home, that's fine. Primary schools have been open all the time. Nursery homes have been open all the time. Sports for children and adolescents have been allowed all the time. Shops are open, restaurants and cafes open, but people are told to keep distance, 1.5 to 2 meters. Communications are going, like underground, trains, buses, and so on. Now, what happened regarding deaths did this lead to a disaster? Well, you can absolutely see here that there was an excess death rate during some weeks in April mainly, and it still continues, but it's going down now. But I want to show you this slide, because this slide shows, if you look at what is called here Series 4, that was 2018, and altogether actually during 2018, which was flu and not COVID-19, almost as many died that year so far as 2020. So 2018, there were many weeks with high death rate and excess rate of death, but no black headlines and no effects on society. Here you see, if you look upon different ages who have died, and then you look, the above is male and below is females. Then you can see that in the age group of up to 64, there is no excess deaths at all. Between 65 and to 79, there is some excess. The main excess of death is above 80 and above 90. Especially you see for females, but also for males. If we compare with other countries, Sweden has definitely quite many deaths. And that is, as I have shown you, just very old people, mainly very old people. More than 90% of all deaths, 92% are above 70. But we have in Sweden, although we had no close down, no lockdown of society, we had less mortality per 100,000 than France, Italy, UK, Spain, Belgium, but more than some other countries, definitely. Here you see a slide from CDC, where we can see how different countries here, we have looked and put Spain, UK, Italy, Iran, France, Sweden, and United States. And you see with time, several countries tend gradually to get similar rate, death rate. And interestingly enough, although the others have closed down, the other countries, and locked down their societies very much, and Sweden has not, there is no big difference in death rate. We have been able all the time to have enough intensive care units open. So in that way, the idea has all the time been to decrease spreading of the infection, to be able to flatten the curve, and be able to have enough of intensive care unit. And as you see, we have had more than 2,000 patients in intensive care unit because of COVID-19 so far. 74% of them had risk factors. And the most common is hypertension, diabetes, and chronic heart-lung disease. So in conclusion, Sweden has had and has no lockdown of society, but assisted isolation of vulnerable groups, especially old people, and general recommendations on hygiene, distancing, etc. We have all the time had 20 to 30% reserve of intensive care unit beds. The number of deaths are lower than many European countries with strict lockdown. Deaths, 92%. I saw the figure today. Today it was 92% older than 70 years of age, many with other diseases. And actually, many of these people had, of course, short expected survival anyhow. We have had a rather high proportion of infected, of course, as we had such an open society, compared to neighbor countries where Denmark and Norway have seen only about 1% of the population, Spain 5% of the population immune. We are up in certain areas at least to 20-25% of the population. And there are already certain trends towards herd immunity. The number of infections are going down since middle of April, and the number of deaths per day is going down continuously since mid of April. And which I forgot to put in this slide, I heard one of the presentations, the first one from Israel, where unemployment had increased, if I remember correctly, it was from 3.8 to 24%. In Sweden, the unemployment has increased to 8%. And I don't say that Sweden is not influenced economically, because we have been very much influenced economically, not least because of the closed borders. Sweden didn't close the borders, but other countries around closed the borders, and therefore all export industries and of course tourism and so on has gone down a lot. But on average, the Swedish economy and the Swedish system has not collapsed in the same way as in several countries. But the policy, as I said, has been quite different, but it seems to have been working rather well. And a reason, if you wonder how it comes that Sweden has made this approach, is that it's not political leaders who decide the approach, but it is experts from the public health authorities who decide the approach. Thank you very much. It was very interesting. Thank you for the possibility to give this presentation.
Thank you, Dr. Johnny Ludvigsen. Thank you very much for giving your fighting with coronavirus in Sweden without lockdown, without lockdown. Thank you very much. A very nice new experience. Thank you very much. Invite our next speaker, Dr. Khalid Al-Madani from Saudi Arabia. He's a consultant in clinical nutrition, member of the board of Saudi Society for Food Nutrition of Saudi Arabia. Dr. Khalid Al-Madani, please.
Yes, sir. I'm here.
Welcome, Dr. Khalid Al-Madani.
Yes,
welcome.
sir. I'm here.
Welcome, welcome.
Thank you. It's my pleasure, my honor to be part of this activity.
Welcome.
Like this is okay?
Yes, yes. Go ahead, please.
First of all, I would like to thank the organizing committee for giving me this opportunity. A special thanks to His Excellency Professor Tomar.
Thank you. Thank you.
This is actually the map for Saudi Arabia, just to show you Saudi Arabia. Yeah. Saudi Arabia has taken the biggest hit from the coronavirus pandemic and the dramatic fall of the oil price on the world market. Today, the kingdom has proven to be one of the first country to have the ability of managing of this crisis. As we can see, the crisis and health disaster management system, which in Riyadh under the supervision. Can you hear me? Can you hear me, sir?
Yes, please continue.
Under the supervision of the Ministry of Health. But first of all, I would like to give you some data about the coronavirus. Actually, the total number of the patient in Saudi Arabia was 78,045 and one. And the active one were 27,000 94. The treated person was 51,022, and the death total was 425. The R0 in Saudi Arabia currently is 1, and the upper limit, which is the maximum reach, that's before reach 4. So when we're talking about Saudi Arabia, about the Center for Crisis Health Disaster Management in Saudi Arabia, which like something has to do with collecting all the data. So they presented the authority in Saudi Arabia, the decision maker, to decide what's going on and what's supposed to do. The government of the kingdom is one of the first countries to sacrifice the economic and development aspect in the profession and deed for the sake of the preserving the safety and citizen and the resident. When we talk about working government department, prevent gathering and airport, school, mall, cinema, any venue has to do with social entertainment was quickly closed, and also preventing minor pilgrims and visiting for the Holy Two Mosque and other precaution and measure to preserve the safety of the human being in Saudi Arabia. And also the Ministry of Health makes some kind of protocol for the surgeon capacity for this particular people. And this include number one, guidance for the daily activity. When we mean by guidance of daily activity, we mean that this include method of transmission of the coronavirus, symptoms, and how can we prevent it, proper way for wash your hand, and also important sanitation them, and also what is the wrong behavior, as well as some tips following open appearance of the respiratory symptoms, and the right time and the proper way to wear the mask. When we talk about the screening, the government makes some kind of application in the telephone, so it will be more easy. In this case, we save the time and also save the load on the hospital. When we talk about the healthcare facility, we talk about demand and availability. When we talk about telemedicine, it's remote education for the public and also for professional. When we talk about supporting the hospital, we can support the hospital with volunteers, retired paramedical personnel, extra beds, equipment, ventilation, all this kind of support for the hospital. When we talk about non-citizen care, they treat exactly the same as residents in Saudi Arabia. Also, when we talk about developing file hospital, design a specific hospital for the coronavirus patient, and also hospital file manual, it was specific for each hospital. And when we talk about the financial assessment, Saudi Arabia, along with the tightening of the curfew hours, the government's announced a series of multi-billion reals worth of financial assessment program to help out the private sector hard hit by the effect of virus and the change of the business environmental. Also, when we talk about protocol, the Ministry of Health make a specific kind of protocol for dealing with the patient according to the recommendation and for the WHO. I finish with many thanks and may God bless you all.
Well, Dr. Khalid Al-Madani, thank you very much for a very nice, elaborate presentation. Thank you very much.
It's my pleasure, my honor. May God bless you all.
Thank you. Now I will invite renowned speaker, my friend, Dr. Anil Dhawan from UK. He's a Director, Research and Innovation, King's College Hospital, Pediatric Liver GI and Nutrition Center, and Mowat Labs, King's College Hospital, London. Dr. Anil Dhawan, please.
Hi, Balvir.
Thank
Ladies
you so
and
much.
gentlemen, very nice to see you
Thank you
all.
so much,
And
Anil, joining. Thank you so much.
thank you. It's a pleasure to join you. So, first of all, I'm not a virologist, I'm not an epidemiologist, and I'm not a public health person. So, my perspective of coronavirus is as a user, as a person who looking after people in the hospital, and what is the life living is like. So, most of you see the media. So national scene is UK. We haven't done that well. We have lost more than 40,000 people so far. Countries so-called lockdown and been gradually been lifted, but our lockdown was not been like a curfew. We were allowed, healthcare professionals were allowed to go around. Similarly, all the people with jobs, if they couldn't do their job from home, they were allowed to go to work. So it wasn't a curfew like in India or other countries that I'm aware of. So life for me as a healthcare professional, for my wife, are both doctors, has continued pretty much normal, if you ask me. Now, there is a difference between pediatrics and adults. Fortunately, pediatric services are not that affected, but our intensive care was taken over by the adults. So we gave half of our intensive care to adults, so to increase their capacity. So King's College Hospital, within 10 days, were able to increase the intensive care capacity from 80 beds to 150 beds, ventilated beds. So that was doubling the capacity by converting intensive cares, recovery areas in the operation theater and pediatric intensive care unit. But we did, with foresight, insisted that nonetheless normal diseases will continue. I deal in children with liver disease and liver transplantation. We have one of the biggest units in the Western world. And so we have to continue that. So we earmarked 4 beds, 4 intensive care beds for children for liver disease, liver transplantation. Hence, we continue that activity. So we didn't suffer that. Some of our junior staff were sent to adult units to help them out. So the consultants stepped down and we did write on calls so that covered the junior middle grade staff. Our A&E department became very, very less busy. There were rarely any patients to be seen for the first 6 weeks. Now we are seeing, and the problem that we are having is that during this time, in 2 months, I think we have missed a lot of conditions which would have come to us. And unfortunately, we will have a delayed diagnosis of biliary atresia. We will have a delayed diagnosis of other illnesses which they should have come. I think people are scared of coming to hospital, so they are not coming to us even if they have an illness. Now, I wanted to bring to your attention, although children are less affected, but you may have seen in the media already and in Journal of Medicine paper that and Lancet paper that certain children, a very small group, are presenting to you with the acute shock-like syndrome. They are presenting like Kawasaki disease. So they do not have classical Kawasaki, but they have all the component of Kawasaki, meaning they have 2 of their patients have aneurysms, coronary aneurysms, they have myocarditis, they have arrhythmias, they have rash, they have shock-like state. And in total, we have seen about 24 children presenting like this. And that is unusual. And we think, and others think, it is related to coronavirus. And there is a pathogenesis that how systemic inflammatory response is triggered. So as a pediatrician, my only advice is that if you come across a child who is behaving like an acute shock-like state, please consider this differential diagnosis, and the treatment is with immunoglobulins, broad-spectrum antibiotics, and that is pretty much it you can do. But they do need a support. Now, one of our patients require an ECMO also, and 3 of them require an intensive care. We did lose one child to COVID, who was a 14-year-old, and he died in our intensive care unit. So we have seen mortality with COVID. The overall picture in pediatrics is not compared to anywhere to adults. They tend to be less symptomatic and suffer less from serious complications like adults have. Nonetheless, it has brought a lot of logistic issues. How to continue working, and what we have set up nowadays called recovery and reset plan. I think if you are in that phase, I think UK is now coming out of it. So our number which the gentleman from Saudi Arabia was saying, we are running at our value of somewhere around 0.7. So our mortality has gone down. We are still seeing new patients, but they are nowhere near. So just to give you an example, 4 weeks back, we had 500 patients in our hospital and about 106 on intensive care. Now that number has dropped to now less than 100, and there are only about 32 patients in intensive care. The problem is once these patients are in, they tend to stay for a long time, 3 weeks to 8 weeks. So they take longer. And the people who have recovered, they take longer to recover also. What we have taken this opportunity to do some research on it. So we have found that the inflammatory syndrome, we are looking at mental health issues. We also found that Black and ethnic minority group patients. So Black and ethnic minority in UK are people who are from African origin or Asian, Indian, Pakistani, Bangladeshi origin, or anybody else. And mortality in that group seems to be higher. So there is a 4-fold increase of mortality in this population. And I belong to that population myself. And it so happens that our population, Black and ethnic minority, have a higher incidence of diabetes, hypertension, obesity. So I think those things are contributing to that. Whether there is a genetic predispositions, we don't know that yet. There is a work going on, but at the moment, there is no data to support. But so what is the practical implication of it is, a lot of staff in the hospital is Black and ethnic minority. So how do we deal with it? So we are risk stratifying. So we are having risk assessment of every staff member who belongs to this category. And we are looking at the risk factors and mitigating against them. We are trying not to put them in the front-facing areas if we can avoid. If they are going to be there, they are going into the full PPE gear then. So it is quite a sensitive issue at the moment for us. But if we send all our Black ethnic minority people home, there won't be many people left to run the hospitals. So it's a practical problem for the country. Whether you are seeing that kind of phenomena in India, fortunately, it looks like what I'm seeing in the media, the mortality is very, very low. The infection rates are nowhere near what we have seen. So we have few 100,000 patients at the moment positive, tested, and we have tested about 3.5 million people in UK. And the daily test rate is about 110,000 patients are tested every day. Going forward in treatments, remdesivir is the only treatment that has come out now. We have participated in multiple drug trials, including hydroxychloroquine that has stopped now, plasma rich from patients who had COVID. That trial is ongoing at the moment. And similarly, and then with the mesenchymal stromal cell as a treatment for adult respiratory distress syndrome is another clinical trial. So there are tremendous research opportunities in terms of understanding the mechanism of this disease. We also know that these patients are procoagulant. They're thrombosing their small vessels and medium-sized vessels. So anticoagulation is a standard treatment at the moment with heparin when they start going into intensive care unit. So anticoagulation, antiviral, remdesivir, and some of them are requiring high-frequency oscillation or ECMOs, very small number. Going forward, antibody testing has started. So we have got a validated test now that will tell us what kind of exposure we already had. And everything has to be rationed. So we can't offer it to everybody. So we are giving to the high-risk population. And with time, every member of the staff will be checked. Problem we are having is working. So what we have done so far, we have 50%, we are aiming now, all of our outpatient activity will be telemedicine. And that is going forward. That's not going to change. So we will, going forward, we will reduce people's outpatient visits. So that program, we have the computer programs, or you will already have many. So that's what the future plan is towards what we can learn from it. The biggest problem is going to be, we think that this virus is going to be there for a long time. So hence, we are changing our hospital geography into COVID-free and COVID areas. So there will be green zones and blue zones. And that is quite a challenge to divide the state between clean and non-clean so-called areas. It's a massive challenge. So we are working on it at the moment. Rapid testing has started. So we get a 6 hours turnaround time to get an antigen test, and maybe next day for the antibody test. So it has been a financial drain. It has been on all fours of drains. But nonetheless, I think on pediatric side, we have done reasonably well. Activity has continued, but we are expecting a small peak in July, and then we're expecting another peak in December. So the national plan is to double the intensive care capacity of the whole country forever. So to be prepared for it for a long time. You may have heard about a hospital, 5,000 bed hospital was created. We only used 40 beds in there. That hospital is there. It's closed now, but it could be opened anytime if needed. So overall, I think as a human loss, the country has not done very well. We are not proud of ourselves. The UK is second to United States in terms of mortality. So we have lost a lot of people. We have lost a lot of people in the nursing homes. We have lost young people also. Unfortunately, from Black and ethnic minority population, there has been a healthcare professionals, many doctors, many frontline nurses, technicians have succumbed to this illness, and that's very, very sad. Nonetheless, that hasn't stopped us. We have concentrated on staff well-being, so making sure that staff are kept happy and as much as we can. So we have opened what we call well-being hubs. So in the hospital, there are areas where people can go. There's a free food. Charity people have been very, very generous. Big enterprises, big hotels, restaurants have given food. So they can go there, sit down and chat. So that has kept the morals up. The society in general has come together. Every Thursday evening for 8 o'clock, there is appreciation for NHS. So those are the things that society is doing. It's in supporting us. We did have a problem with public, our personal protective equipment, like anybody else. Things are much, much better now, but we had to ration it initially. But nowadays, I think TP is not an issue anymore at the moment. Ventilators, we did require we did procure in excess, but we never used most of it. So currently in UK, London was the peak pandemic in the eye of the storm, and all the patients who needed intensive care were justified to have had it. Ventilators were there, already procured from some other sources. So it wasn't a crisis that what we predicted in terms of intensive care utilization and bed capacity. So fortunately, we managed to flatten the curve. It's much lower now, and we are hoping that we will prolong the tail as much as we can while we wait for vaccine or another effective treatment. And I thank you very much for listening. I don't have slides. As I said, I'm not an infectious disease virologist. I'm a hospital management person and a frontline clinician. Thank you very much.
Dr. Anil, thank you very much for joining us. And thank you very much for giving a very elaborate scientific information to us regarding the acute shock syndrome like in children's, Kawasaki disease like presentation, rest, and the getting more effect into the Black and minor ethnic group of the society in UK. So thank you very much. I'm really grateful, Anil, for joining us. I'm very grateful. Thank you so much.
Pleasure always.
And as a very short notice. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.
Now I will invite Dr. Idirgo Sagaro, please, from Cuba. Dr. Sagaro from Cuba. He's the president of Cuban Society for Gastroenterology of Cuba. Cuban experiences.
Thank you very much for your gracious invitation. Well, none of the countries of the world can face the COVID-19 pandemic alone. A global response based on solidarity and multilateral cooperation is needed. We should complement each other, share what we have, help each other, and learn from each successful experience. What we achieve depends not only on our individual efforts, but also on the response of each to this unprecedented worldwide calamity. Cuba enjoys a free medical care system for all our citizens, with 9 doctors for every 1,000 inhabitants. Our medical system covers 100% of the population. Cuba has also developed a biotechnological and pharmaceutical industry with novel products for the treatment of this COVID-19, such as alpha-2b interferon, CIGB258 peptide, and others. These novel drugs improve immunity and control the inflammation of the lungs. See the figure 1. Figure 1 is the clinical trials that we are doing in this country with biological Cuban products, some to stimulate immunity and some to reduce the inflammation. The stimulators of the immunity are the CIGB20, biomodulin T, alpha-2b interferon that has been used in China and in other parts of the countries, the same in Cuba, and the transference factor. To reduce the inflammatory response, we use monoclonal antibodies and the peptide regulator of the inflammatory response. The survival rate of critical ill patients using this drug is over 75%. Around 70 investigations and clinical trials for the treatment of this infectious disease are ongoing. Cuba has controlled the pandemic with the full mobilization of our medical system. Here you can see children in Cuba preparing in the schools before they were close to face the pandemic, how to sneeze, how to use their masks. Before March 11 of this year, a very elaborate national plan was launched in accordance with the protocols of the World Health Organization. A daily follow-up of the plan has made feasible the epidemiological surveillance of an early diagnosis and a proper treatment. This is more or less the plan, the strategies of prevention, research for the development of vaccines, and to be a step forward in the epidemiological measures, one step forward, with social isolation, active massive tracing, and isolation of all confirmed cases, suspected cases, and all contacts in hotels, touristic resorts, schools, etc. Our airports were closed for international flights. The spread of Cubans was encouraged. The passengers at arrival were under strict epidemiological control. The island mandatory confinement was not decreed. People was urged to stay in their homes and to comply with social distancing. Factories that were not essentials were closed and all workers were provided with social security. The circulation of transportation and passengers was restricted. Daily, thousands of people were visited by medical students, nurses, and family doctors. They were interviewed about possible symptoms of the disease. All suspected patients were reported and followed up on. The priority was to find and isolate all the cases, not only those with SARS-CoV-2. Also, all people with suspicion of having the disease and contacts of confirmed cases were required to be isolated in hotels, touristic resorts, and schools, adapted as isolation centers. Secondary contacts had to stay in their homes where they were visited by family doctors. This is a Cuban special feature. Complete hospitals were assigned to treat only patients with the disease. Neighborhoods where local transmission was detected, there were 44 now, only 9 are active, were temporarily isolated. Mass production of face masks was done by factories and immunization by voluntary work, mainly women. Daily briefing of the state of the pandemic in Cuba and the world were given by television and radio stations. As soon as they were received in the country, the PCR assays and rapid diagnostic tests they were done. The number of tests were increasing progressively. All university and research centers investigated essential aspects of the SARS-CoV-2 infection according to the profile. Here is a figure of a scanning microphotograph of SARS-CoV-2 in the surface of nasal epithelial cells. A Cuban patient in panel A, normal people, and in B and C, you can see samples of SARS-CoV-2 in the yellow arrows in the Institute of Tropical Medicine, Pedro Curie in Havana, Cuba. The main research questions were, which is the best treatment? What is the role in the treatment of the Cuban biotechnological products? Can Cuba produce the diagnostic test? What mathematical methods could help to assess the progress of the disease and to implement epidemiological measures? How can we find a vaccine against the disease? On May 28, 70 days after the beginning of the disease, Cuba reports 1,983 confirmed patients, 82 people died, 4.4.13 as mortality rate, and 98,403 tests done. This is the curve of the epidemic in Cuba. As you see, the peak was crossed, and now we are going lowering the number of cases. The Cuban health system did not collapse, but rather managed to control the epidemic and is on the road to eradicate it. All of this have been achieved under a very difficult economical situation. Before the pandemic, 29,465 doctors were working in 59 countries. Now, 24 countries ask for their help in the struggle against the pandemic. Cuban health collaborators voluntarily offered to support these countries. 43% of them are working in the red zones, risking their lives. Cuban nurses have played a distinguished role. Many countries have asked for them. 2 Cuban doctors working in Kenya were abducted and taken by force to Somalia by a terrorist group. Health constitutes a common and indivisible heritage of the whole humankind. The COVID-19 pandemic represents a serious threat for all countries. The number of new infections is rising daily in every continent. Countries with comparatively limited financial means are facing greatest difficulties in their struggle against the pandemic. This is particularly true when the virus spreads in countries where the population already endures difficult living conditions due to different causes, such as unilateral coercive measures. We express our deep concern about the severe impact of unilateral coercive measures on the dramatic consequence of this crisis. We urge the immediate lifting of all unilateral coercive measures against Cuba, a country which is playing a critical role in stopping the pandemic. COVID-19 must serve as a call for a global solidarity rather than economic war and devastation. Thank you very much. Merci beaucoup. Gracias. Obrigado. Spasiba. Thank you very much indeed. Chico? ¿Qué hago aquí? Chico? Thank you.
Yes. Thank you, Doctors Sagaro. Tthank you very much for joining and giving your Cuban experience of fighting with COVID-19. Thank you very much. Now I am inviting my important speaker, Professor Marinela Herrera from Venezuela. He is a professor of Universidad Central de Venezuela. Central University of Venezuela, and we will listen from him the Venezuelan experience of fighting with COVID virus. Professor Marinela Herrera, please.
Thank you very much. Thank you to you, Dr. Balvir. A pleasure to see you again.
Thank you.
And to the organizers for this wonderful initiative. So in Venezuela, we have 2 crises coexisting. The first one is the pre-COVID humanitarian complex emergency that we have. And so that gave us a very particular experience. We have been mentioned in the latest food crisis report as the 4th worst food crisis in the world. So we had to make extremely careful about the measures we have to take for protecting the most vulnerable population so they can face appropriately this crisis. So we have basically a lockdown in the country from March 17 And the measures, of course, included social isolation, staying at home, and avoiding large group of people. But the situation was really, really severe in terms of food insecurity. So as the World Food Program stated in the latest report, we have 9.3 million people of living in food insecurity, moderate or severe, and 33% of the children between 0 and 2 years old were already presenting growth retardation, meaning that they are in the first 1,000 days window. So this is a very critical period of time. So we were encouraged to develop protection programs by UNICEF and the Office of Humanitarian Affairs that are currently in the country. More than 60% of the families are using coping strategies for survival, and the health infrastructure of the country was not really prepared to face the pandemic. Because, I mean, we were lacking on water and some public services that we needed and that were essential to work properly during this pandemic. Today, as per today, what we have now is 1,325 confirmed cases. Recovered, we have 302 patients, and 11 people died from this. But according to the Mathematical, Physical, and Natural Science Academy, in the projection model, they expect to have the curve rising in the next few weeks. So we need to be very, very careful, because the model, as the most conservative scenario, shows something, a number, a figure like 1,000 cases per day, and the worst scenario shows 4,000 per day. So we need really, really now to extreme the measures, the hygienic measures, and the protection for the people. So our challenges now is dealing with food insecurity and understanding that poverty will increase during this lockdown, because, I mean, the dilemma is economics versus epidemiology. How do you deal with that? Besides that, we have a migratory movement between Venezuela and the neighboring countries who have been affected by the Venezuelan crisis. And many people, because of the lockdown in neighboring countries, are coming back to Venezuela, so they can be infected with COVID from Colombia or from Brazil, and they are returning to an already affected country like Venezuela. So measures and recommendations, of course, as I've mentioned, the government took measures of isolation. They are recommending frequent hand wash, recommendation, staying at home, use masks if you are going to public spaces, restaurant, and other food vendors are working or should be working in delivery or pickup mode, and schools and universities are in online with many difficulties because of the lack of appropriate services. But also at regional level, the Latin American group of experts on nutrition recently made a consensus that is published at the Latin American Society of Nutrition webpage, which I am sharing here, and I invite all of you to check on the Latin American Society of Nutrition webpage for more on that, because we have also 2 documents for recommendation. One it's for the health workers and the second line of workers, which can be at the supermarkets or people making delivery or working on pharmacies, etc. And also a document for prevention of COVID-19 in the context of undernutrition. So all that is available at the webpage of the Latin American Society of Nutrition. Well, and for us in Venezuela, the dilemma is economy versus epidemiology. How do you manage a crisis in a country that has the context of hyperinflation, the highest in the world, and you just telling the people, okay, stay at home, don't work, but people need the income to feed themselves and their families. And how do you really achieve to make a balance between the economic aspect and the epidemiologic aspect is really a challenge. And as Bill Gates said in his previous statement, even in 2015, he was kind of a visionary because he somehow predicted that the world would be facing a new pandemic. And in the article he wrote, by the end of February at the New England Journal of Medicine, he had some kind of statement that were very interesting, saying that for the leaders, the most important thing is help the people in need, but also try not these events to recurrently happen. So how do we prevent this? So it means that we have to take care of the urgent, but we cannot lose the relevant and the important, because one have the tendency to help the people and save lives, and then you forget about the structural things which are really relevant, thinking over the long term. So what are we doing? We're trying to learn the lessons, we are documenting, we are making research, we are publishing, and the great work of the civil society and NGOs, academia, industry are working really hard along with UNICEF and the OCHA agencies present in the country, because we need to make prevention, and we cannot allow this to happen ever again. Thank you very much.
Thank you very much, Professor Mernila Herrera. Really, I'm grateful. Thank you very much for joining us and giving a very excellent, enthusiastic approach regarding fighting with the coronavirus disease. Thank you very much for joining us. Now, after listening to you people, most learned scientific people, the experience of most countries of the world, I'll take few minutes to give the Indian experience. I'll take only few minutes because you have spoken a lot. India has huge population of 1.3 billion. Still, the total number of corona cases in India as on date today is 166,000. Rank-wise, it's 9th number in the world. But if we count the death, total death till today are only 4,706, and mortality rate is coming 2.8%. Another important point which I would like to put forward, then 80% cases in India, they are asymptomatic or very mild symptoms. And once we say mild symptom means, we are seeing the cases like symptoms like headache, muscle pain, pink eyes, loss of smell and taste, intense chills, some rigors, and some sore throat. Corona comes and goes out. So these are our corona cases which are symptom, mild symptom, no symptom, asymptomatic. So this group, we are having 80%. So this is the scenario in India, and how the India has taken, after such a huge population of 1.3 billion, death rate of 2.8%. I can now divide the whole world, after listening you people, the whole world into 3 groups. Group 1, there is a complete lockdown, forceful lockdown, as India, Israel, and many more countries. You have listened here. Then second group of countries, which are having very minimum, are probably no forceful lockdown, like UK, US, Canada, and European countries, mostly the forceful lockdown. But third example is no lockdown at all, like Sweden example. So I can divide like this way. Now, how with this great population of 1.3 billion, how the mortality rate in India is only 2.8%. I will invite my friend who is director in the NIMS University, Dr. Pankaj Singh, a renowned neurosurgeon, who will speak how this India has taken its mortality only on 2.8%. Dr. Pankaj, please. India has taken this very small death rate, very happy, but 2.8%. Dr. Pankaj Singh from Director NIMS University will be giving a 2-minute speech how India has combated this thing.
So good evening, good afternoon, good morning, all of you. It was a very insightful evening with all of you. Can you hear me?
Yes, yes, yes.
Okay. So guys, thank you very much for all your time and effort invested. Now, in continuation with Dr. Tomar, who has showed some light how India has got affected with this situation, I'll continue the same talk, and I'll discuss what are the different challenges we have faced and how they were tackled. So India has got its own challenges. It is a very diverse country in terms of geography as well as in terms of manpower. Now, one of the most important challenges was India was facing was the limited resources, and there was a very high discrepancy between the population in terms of there is a big divide between rich and poor. At the same time, there was lack of awareness, and lots of people, they did not know what is corona is all about. So this was tackled by a number of ways, and it can be divided into 5 important parts. One of the important aspect was the leadership. So Mr. Modi, who is the Prime Minister, he basically took the challenge in a very prompt way. And the first thing he did, he imposed a very good lockdown. I would say India has a very, very good lockdown, one of the best in the world probably, and that has slowed the community spread, and that has slowed the contact in India. The second thing that has played an instrumental role was the healthcare professional. The healthcare professional, they came forward with their own initiative. They put their lives on risk, and it is an untold story, which I would like to emphasize, and all of us, we have shared the same thing, and India is no exception. The third part was basically the general public. The awareness was raised using social media and different platforms, and eventually the general public took the responsibility of social distancing and not coming out. For the first time in my life, I've seen deserted cities, the deserted streets where no one was out, and that was a very commendable job from the public point of view. And one of the important steps Indian government took was the application of technology, the timely application of technology with the help of one of the app which keeps everybody at the bay. So we could basically inform them, and they could assess their own symptoms at the home, and they could monitor it. It was one of the important apps, which was it's called Arogya Setu in Hindi. And one of the last step, which is I think one of the most important thing, why India basically is showing such a low death rate, especially, is I think its herd immunity. Indian population is prone for lots of infection right from the childhood, and because this virus has got a genome sliced from Plasmodium vivax, which we have been demonstrated in Fraunhofer's Institute in Germany, and that I think played an important role in generating herd immunity from India, and that was instrumental for low death rate. So these are the few factors I shared with you, and thank you very much for listening. I'll invite Dr. Tomar again for his closing remarks and a vote of thanks. Thank you very much.
My all dear friends, are you listening me? So my dear friends, Dr. Manuel Katz from Israel, Dr. Vana Spoulou from Greece, Dr. Liang, Choo from Malaysia, Professor Dr. Ron Sapiro from USA, Dr. Deepali Tewari from USA, Jay N Shah from Nepal, Abdul Rahman Hamid from Afghanistan, Dr. Christian Jetun from Cameroon, Dr. Medina Orsi from Argentina, Dr. Irkin Yakubo from Uzbekistan, Dr. Johnny Ludwigson from Sweden, Eduardo Sagaro from Cuba, Dr. Khalid Al-Madani from Saudi Arabia, Dr. Anil Dhawan from UK, Professor Marinela Herrera from Venezuela. Well, I personally thanks to you people for joining us in a very short notice and very elaborate scientific information sharing on this dais. Thank you very much, my friends, my people, meeting you, all of you, after a couple of years. Now, we can, before I speak 1 minute more, then will be open for discussion. I am thinking, I am making a committee for fighting of people like you people who have joined us now, a space, a dais, which can be made globally. We have many other people also who can give suggestion to fight infectious diseases or any such diseases which may become a pandemic or become an endemic or any part of the country. So that will be a group of people. I am including those people and forming a group of people fighting globally or advising globally for such things coming up in the worldwide. And second thing is that my office will write you. You can send your presentation. We can publish in the journal and in the book form. And that book will be sent all over the world, all over the countries, and you people also. So that can be a very well experience for the all people, community, country, all things, everywhere. So these are the two my recommendation to all of you. And now, if anybody wants to ask any question, unmute karna padega. Any questions, you can unmute yourself and you can ask any question from anybody if you want for 2-3 minutes.
I can just wanted to thank you. I think that is so important to bring people from all over the world, from different continents. And when you bring from different continents, you see different type of COVID-19 because in fact, I think, you know, this epidemics is so tricky in some way. Started in China, from China to Europe, from Europe to Asia, or from China to Asia, Europe, from Europe to the United States, and United States to Latin America. And I hope that we'll stay there and we will finish there. But I think that will not be the case. Probably we'll start again according with the time, according with the winter time in different places in the world. And I think that we are facing also replications of the virus and different type of subtypes of virus that have different type of phenotypes, because the gene is changing, the phenotype is changing, and then you see in pediatrics different type of diseases like the Kawasaki-like disease and other features that in China were not there. This is very, very interesting features, and very difficult for all of us to have a unique type of management and unique type of thinking of how to deal with this problem, because even we don't know why in children is so different like in adults. We have some theories, but no more than that. And also the treatment, because as was written by the Cochrane group, nobody said that we have only one medication that works in COVID-19. This is still, we have severe problems in the medications, and only, support techniques and good support techniques and good ICU, they save life. Thank you, Tomar.
Well, Dr. Manuel Cott, thank you so much. Because as you spoke is correct, as Dr. Anil Dhawan has spoken, then they have seen in children acute shock-like syndrome as one way. And second point is that in India is having 80% mild symptom and no symptom like that way. So really it's a very great presentation of coronavirus. So we are going to combine together and present towards the world what is going on.
Yeah.
Dr. Shah.
Yeah, it was good. It was good listening to all of you. And basically what I see, because at the height of this, that time it was still epidemic, late January, from 24 to mid-February, I was in Shanghai, China. And so I could see firsthand how it was in China that time. From end of January to February. And then when I came back to Nepal, what I see difference is the experience of the earlier Chinese, the Korean, Hong Kong, Singapore, and this experience of isolation, social distancing, using masks, and all these things had really solved the problem, which probably what we see in Europe, starting with Italy, UK, and then now we see very tragedy in America. What I see sometimes is probably we in scientific world, it doesn't have to be science, has to be from the top down bottom. Science experience can be from anywhere, any countries. What I see Asian experience, probably if it had replicated Europe and America, the tragedy would happen probably better. So this is a very good opportunity for us to combine the experience of around the world and see what evidence says. It doesn't have to be the developed country or underdeveloped country, like say India or Nepal or China or UK or America. Everybody has their own experience. So this evidence-based medicine probably has to be accepted by all of us.
Thank you very much.
Thank you.
Well, Dr. Vana, Spoulou from Greece, want to tell anything, please? Dr. Deepali Tewari, Dr. Ran Sapiro. Now, Dr. Marina Orsi would like to add something or any questions? Well, so thank you very much, my dear friends, joining with us. Great morning, afternoon, and great evening and night in India. Thank you so much. And we are forming a global informative group for the globally people to come back with any disease, maybe corona or some other thing like forever. Thank you very much. Thank you very much.
Thank you.
Thank you very much.
Bye-bye. Thank you very much.
Thank you.